Good early morning, good afternoon, good late evening, and everything in between. Thank you so much for dialing in and welcome to this webinar on expanding access to good practices on the elimination of mother-to-child transmission of HIV and syphilis through South-to-South cooperation. The webinar is hosted by socialprotection.org and organized by UNICEF, the International Policy Center for Inclusive Growth, and the United Nations Office for South-to-South Cooperation. We have a really packed and fascinating agenda today. We will start with an overview on the elimination of mother-to-child transmission, which I shall now call EMTCT, and then we will move into presentations from Thailand, Malaysia, and South Africa. Finally, we will have a bit more depth on syphilis. I will introduce each of our 5 speakers before they present, and we will take 1 or 2 clarifying questions after each of the country presentations, but then we will have a longer Q&A at the end of all of the presentations. To our panelists, welcome and thank you so much for joining. It'll be important that we keep to the time in order to have a good discussion at the end. For our audience, please do write your questions and comments at any time during the webinar into the chat bar, and please make it clear which speaker you are addressing your question to. Thank you. Now, moving along. Trying to see if the slide will change, but maybe not. Okay, this is to encourage you to please, if you are not already, please join the community of practice on South-to-South cooperation for children. We'll mention this again at the end of the webinar. My name is Mbori-Ngacha. I am the Senior Health Specialist at UNICEF Eastern and Southern Africa Regional Office. I'm based in Johannesburg, and I focus particularly on EMTCT and pediatric HIV, and it's very much a pleasure to be here with you today. So, not to go on too long, I'd like to introduce our first speaker, and first up is my dear colleague, Dr. Dorothy Mbori-Ngacha at UNICEF New York. Dorothy is the Senior HIV Specialist on EMTCT and Pediatric HIV for UNICEF's Global HIV/AIDS programs. She is a medical epidemiologist with specialist training in pediatrics, infectious disease, and child health. Dorothy has extensive experience as a public health professional working in academia, the public sector, the NGO community, as well as international organizations. Currently at UNICEF, she supports efforts towards achievement of global targets on EMTCT and to attain universal treatment for women, children, and adolescents living with HIV. Dorothy is a national of Kenya and holds a medical degree and a master's of medicine in pediatrics from the University of Nairobi, as well as an MPH from the University of Washington in Seattle. Dorothy is going to give us a brief overview presentation on global progress and guidance for EMTCT. Over to you, Dorothy.
Thank you, Laurie, and hello, everybody. It's a pleasure to be speaking with you early morning and whatever time it is where you are. I'm just going to, as Laurie said, give a very broad overview of where we are in EMTCT and really provide some guidance around what we see as the issues around EMTCT, the criteria, and this will just sort of lay context for the very rich discussions we anticipate from the country presentations. Next slide, please. So in 2018, there were about 1.4 million women living with HIV, and collectively were able to deliver antiretroviral drugs to prevent mother-to-child transmission to 80% of these women, which is a really major feat and something to celebrate and count as success. However, despite this high coverage rates, mother-to-child transmission rates remain high globally at 13%, which is way off our benchmark of less than 5%. Next slide, please. So shown here are the global trends in PMTCT in the period 2010 to 2017. The figure to your left shows the PMTCT coverage in green and the mother-to-child transmission rate in the dotted red lines. And the chart to your right shows the number of pregnant women living with HIV who receive ARVs in green, with the proportion with the red portion depicting the number of people living with HIV who are still not reached with ARVs. Both charts tell the story in different ways. After an initial increase in coverage, we are seeing a flatlining of our responses. This is alerting us to the fact that we need to change our strategies to reach the last 20% of women. Next slide, please. So the analogy I like to use is that of a fruit tree. If we think of achieving MTCT as picking fruits from the tree, we have picked all the lowest fruit, which has given us the 80% coverage. So reaching the low-hanging fruit is easy. Now, next, we now have to do things differently to get to the different fruits at the higher parts of the tree. Next slide, please. Next slide, please. Next slide, please.
Can we help to change the slide? Dorothy, they might be a little bit behind you, so I don't know if you could sort of start on the next one.
Okay, so basically the point I'm making is low-hanging fruit is done with. Now we have to be a bit more creative to reach the fruit at the high end of the tree to cover the 80%. Moving on, I'd like us to really think of these last 20% of women who we're not reaching yet with ART as the most vulnerable. Next slide, please. The women living in extreme poverty, women in the most remote areas where access is poor, women who are ethnic minorities, women who are migrants, women who are marginalized because they are key populations or their partners are members of population groups. So as we will hear in our presentations today, as your epidemic response matures, then you need to begin to do different things for these last 20% of women. Next slide, please. Previous slide, please. So now I'd like us to go through the EMTCT criteria, which are very stringent and which everybody is aspiring to, and which we would like to congratulate the countries on the webinar today for having attained. The global criteria require a very high coverage in terms of process criteria of testing, of treatment, and actually service, and actually also service access. So in terms of impact, the global criteria requires that we have less than 50 cases per 100,000 live births, and MTCT rates of less than 2% in non-breastfeeding populations and less than 5% in breastfeeding populations. I think our slides are a little bit off whack, but those are the criteria that we have. We have the impact criteria and the process criteria. Now, actually getting to EMTCT is a challenge in that we have to have so many steps that we need to attain. It's a multi-step process. It's a multi-step process where you're looking to see how to get the women in, you're looking to see how to cover them with the interventions, and we're looking to retain them. I'm a little bit thrown off by the slides. Next slide, please. Okay, so let's stay there. So beyond these criteria, the process and impact indicators, we also have other 4 additional qualitative requirements for validation. So it's not enough that you're reaching all these women. You have to keep the process in place for 2 years, and impact indicators have to be in place for 1 year. So it can't be just at one point in time. This is something that you have to be able to show, that countries have to show that they're able to sustain, and our countries will talk a little bit to that. In terms of in-country geography, we have to make sure that we're not just reaching the easy-to-reach populations and declaring success. We have to show that low-performing subnational administrative units are also reached, and that there are no unattended hotspots. And then in terms of the quality of our program, it's critical that we're sure that our data is robust. So M&E systems have to be really robust, able to measure and accurately tell us where our program is. And laboratory systems also have to be of high quality to be able to accurately detect all cases. And then finally, all our program responses really have to be based on basic human rights considerations. So it's beyond the numbers to some of these other qualitative criteria. Next slide, please. So reaching EMTCT requires a lot of effort. And we will hear that from our countries that will be presenting today. You require sustained commitment from government and health workers, high levels of coverage of testing, treatment, and other services over time. We also need to retain women throughout the continuum from breastfeeding and for life. And we need these robust systems, as we've talked about. And it'll be intriguing to hear from our panel of countries on the specific challenges they've had to overcome as they work towards validation. Next slide, please. One issue that I'd like to flag is the issue around the high burden African countries, because they are performing very well, and South Africa will be presented as a case of a country that's performing at a very high level. The challenge they're facing, though, is because of the high underlying prevalence, the estimated case rates remain above the threshold of 50 cases per 1,000 live births. And this is an issue that WHO is looking into to see how to define criteria in these high burden countries. But nevertheless, WHO has put in place a path to validation criteria that would recognize the progress in these countries. And South Africa will probably be talking to this. Next slide, please. So as I come to the end of my introductory comments, where we have acknowledged that EMTCT has been a very successful program, we've noted that getting to validation is a very stringent process. I'd like to really pause and congratulate the countries that have already had have been validated for dual EMTCT validation. And on the call here today, we have Thailand and Malaysia, who will be representing those countries and will be able to talk to some of the issues. We also have South Africa, which hasn't been validated, but which is a very high achieving country, and they'll be able to talk to issues in these high burden countries. Today, the webinar is beginning to show us the role that South to South cooperation can play in sharing these good practices and sharing how challenges have been overcome so that other countries can join these nations. Thank you very much for the opportunity to present the overview, and over to you, Laurie.
Thank you so much, Dorothy, for the clear presentation and the great slides and pointing out some of the challenges in meeting the criteria and the different phases in the process. We are not going to take questions at this point, so please, if you do have any questions, please do type them into the chat box. We will take a few questions after each of the country presentations. But now I would like to introduce our next speaker, who is Dr. Sarawut Bunsuk. Dr. Sarawut has been a medical doctor for over 15 years and has worked in maternal and child health for over 10 years. He currently serves as the Director of Regional Health Promotion Center in the Ministry of Public Health in Thailand. Dr. Sarawut served as Chief of the Maternal and Child Health Division and Chief of the Maternal and Child Health of ASEAN in 2015-2016. Dr. Sarawut and his colleagues succeeded in driving Thailand's program to validation of EMTCT of HIV and syphilis in June 2016, so congratulations. He has conducted research, developed and expanded interventions for EMTCT throughout Thailand. We are privileged now to have Dr. Sarawut speak to us about the experiences and lessons learned from Thailand on EMTCT and South-to-South cooperation. Over to you. Dr. Sarawat, are you able to turn on your camera and your microphone? There you are. Great. I think you are muted.
Okay. สวัสดีครับ Good morning everybody and thank you UNICEF for inviting me represent of Thailand to share the experience and thank you MC. The next slide. The next slide, please. The next slide, please. Okay. About my presentation topic for today include 4 topics are the epidemic context of MTCT and syphilis of Thailand, and the highlights of the achieved and progress to date, key issues, lesson learned to share to other countries, and the last topic is the key challenge to maintain the success. The next slide, please. The next slide. About the evolution of Thai national PMTCT policy and the guidelines, the national PMTCT policy has been evolved based on updated scientific evidence. The Ministry of Public Health announced a national PMTCT policy and guideline start in year 2000 for all government hospitals to integrate PMTCT of HIV to the routine MCS services, including VCT for HIV, screening for the syphilis and hepatitis B infection among pregnant women. And ARV regimen have been changed periodically according to the evolution of the prevention of transmission and science for a single dose ACT, starting at the 34 weeks of the TA for in the initiate. Starting in year 2000, early infant diagnosis of HIV. Use HIV antibody testing at 12 months in year 2004. And the HIV DNA PCR test was introduced for HIV diagnosis of infant at 1 and 2 months and 2 and 4 months. And in year 2014, the national PMTCT guidelines were modified to classify infants based on the list of acquiring HIV through MTCT as those with standard list and those with high risk maternal plasma HIV viral load more than 50 copies or checking hard for less than 4 weeks before delivery. Next slide, please. The next slide, please. About the HIV MTCT rate report from GAP report of Thailand, we have the data for MTCT rate and the HIV positive in pregnant women. You can see in the slide in year 2000, we have the high rate of MTCT and continue to decreasing. And the last year, we found the MTCT rate is 1.68%. And for HIV prevalence in pregnant women by ANC status, in the last year, we found 0.5%. The next slide, please. The next slide, please. About the result of the elimination of HIV and syphilis transmission for mother to child for the revalidation in the last year, Thailand received elimination of mother to child transmission of HIV and syphilis validation by meeting the WHO target in June year 2016. And Thailand can maintain the EMTCT of HIV and syphilis by meeting the WHO target again in the last year. All the indicator is the main indicator to achieve the target. You can see from the slide. The next slide. The next slide. Although Thailand achieved EMTCT target, we aim to further reduce MTCT rate to less than 1% in year 2013. Remaining cost for MTCT based on the ACC data show that 81% of HIV infants were born to late presenter and poor ARV adherent mother. And we found about 7% were from mother who had zero convert during delivery, and few percent were from some data error from the health system. The next slide. The next slide. About the strategy to reach late presenter and the migrant for MTCT, I think it is the challenge for Thailand to continue and maintain the success. This is the strategy for the late presenter. We provide the HIV rapid test in labor room for all pregnant women with no HIV test result. And if we found the HIV positive, we give the product in the labor and counseling and postpartum, and we provide the formula feeding and no breastfeeding to the infant. And the management is similar to other pregnant women. And in the last year, we have the new policy to provide Leuticavir in additional to heart in high risk MTCT. And for the migrant, I think it's the problem in another country about the migrant. We have to encourage the migrant to pursue the migrant health insurance that provide health benefit package similar to universal health coverage scheme for Thai people, and special project support by Thai Red Cross, DOH, and Ministry of Public Health. And we support formula feeding by NGO, and in some migrant can self-pay for the hospital social fund. The next slide. The next slide, please. About the situation of the congenital syphilis and prevalent among pregnant women in Thailand, the data from Department of Disease Control, Ministry of the Public Health, we can find the rate of the congenital syphilis stood at 11.2 cases per 100,000 live birth in year 2014 and 10.9 in year 2015. These results were achieved through a nationwide systemic effort that resulted in sustained quality services and high level of service coverage and impressive adherence. But prevalence of the syphilis in pregnant women slightly increasing. So we concerned about this issue and developed the program to verify case by case. Maybe in some health system missing, collect the data and report the data. And at some point, we mainly and strengthening the system, we can find the number of the HIV more and more in the recent year. And about the next slide, please, the highlight of achievement and the progress to date. The next slide, please.
Dr. Sarwood, I just want to mention that the slides take about 2 seconds to move, so it's a little gap in between. And also, just to watch the time a little bit, please. Thank you.
Okay. I think we have a component for the important to strengthen the system. The first one is the good health system. I think the important one. And the second one is national partnership and the leadership. For the sustained political and multi-sectoral working, I think so. And the system of surveillance system and research at M&E, I think is important too. And about the financial support, I think the important for sustainability. The next slide, please. I think the best practice of the Thailand is the ACC network. The next slide. In Thailand, implement about the ACC, all of the province in Thailand, I think can share to another country about this. The next, we use the case manager, use the social media and live for real-time case alert to ongoing technical and management support. The next, The next slide. And major challenge to maintain validation of EMTCT. I think increasing trend of the quantitative syphilis, case rate, and prevalence among pregnant women. I think we have to implementation of national strategy for all of them. And the number of the migrants continue to rising. We will cope this issue. The next slide. And key lesson learned to another country, I think the important to share to all of you. I think the policy, the strengthening the MZ handboard in national and regional level. I think we can share and learn to another country. The surveillance system in Thailand, I think is the best practice to share. And about the ACC and the human rights activity of the NGO is important to share to all of you. And through experience and learning with another country, we can, the next slide, we can collaboration with the South-South collaboration for the training of the healthcare worker and transferring management skill and capability management. I think Thailand can to support to another country for achieve the target of the WHO. The next slide. The next slide, please. The recommendation for the successful South-South collaboration toward achieving EMTCT of HIV and syphilis. I think that strengthening the country is a represent role as a knowledge hub and the capability of the organization in provide technical assistance and the capability building support to other country. And strengthening policy all level in each country. Important. Effectiveness of global surveillance and M&E, not only each country. And health literacy system have to implementation. And healthcare service without border. I mean that about the global social funding, important to support the system. The last slide. Acknowledgement, Thailand Ministry of MOPS, Vina from UNICEF, and TUC Dr. Langsima, and another people to collaboration for success of the Thailand. Thank you very much.
Thank you, Dr. Sarwat, so much. That was a really valuable presentation with a lot of rich insights for us. Let's take a couple of questions. I have one here, and the first question is, was financial investment of the government significant to achieve these results, the government of Thailand? Dr. Sarwat, were you able to hear the question? Are you on mute? Dr. Sarwat, we can't hear you. Let me repeat the question. Yeah. Oh, sorry. Go ahead.
Okay. Okay. Yeah, already.
Okay. The question was financial investment of the government significant to achieve these results?
Yeah. Yeah, I think about the financial support in Thailand is different another country because of Thailand we have the health insurance and 30 baht scheme. All the Thai people in Thailand not buy the insurance can fee when go to the hospital, including for the HIV system. And for the migrant people, support by NGO and funding from Princess Somsavali and the Thai Red Cross to support to the migrant people.
Thanks very much. That's helpful. I suddenly have 3 more questions, so I'm going to start with one, and then I'm going to add the others to the question and answer at the end when we'll be coming back to all of the presenters. So this is a question about formula feeding for those who present later in antenatal care. Was formula feeding mandatory for all women, or were they given a chance to accept or refuse?
For the policy of Thailand, all the pregnant women, we have to give the knowledge to the parent to give the breastfeeding to all the children, except the children born from the mother HIV positive. And Thailand have the policy to give the formula milk to all of them. Yeah, and for free. Yeah, until 18 months. And we have the ACC project. If we found the result of HIV result negative in the children, we can to give breastfeeding to the children too.
Okay, so currently in the policy in Thailand, it is formula feeding for women living with HIV who give birth. Is that correct?
Yeah,
Okay.
no breastfeeding to the children. Yeah,
Okay.
they believe
All
that
right.
the positive.
Thank you, Dr. Sarwa. We will come back after the next two presentations. I want to turn, thank you again. I want to turn now to our next speaker, who is Dr. Anita Suleiman. She has 30 years of experience in the area of public health, ranging from providing primary care services to crafting innovative HIV strategic plans, policy development, and a national investment case for HIV. Anita is currently heading the HIV, STI, hepatitis C sector at the Ministry of Health. And was heavily involved in getting the country validated for the elimination of mother-to-child transmission. She has vast experience leading the country's HIV estimates, integrated biological and behavioral surveillance survey, and population size estimates for key populations. Outside of her HIV work, Anita serves as the technical supervisor of the Epidemic Intelligence Program, an in-house training program for public health physicians. Anita will now share with us the experiences and lessons learned from Malaysia on EMTCT and South-to-South cooperation. Thanks so much, and over to you, Anita.
Thank you, Laurie. Hi, everyone. Good morning and good evening, wherever you are. Okay, my next slide, please. Okay, I'll be sharing with all of you about the Malaysia experience in achieving or implementation of PMTCT, HIV and syphilis. Next, please. Now, in Malaysia, we started, if you can see, we started the demonstration project of HIV screening among antenatal mothers in 1997 and rolled out countrywide in 1998. That means about 20 years ago. While syphilis screening among antenatal mothers started much more earlier than that, with approximately 30 years ago. And both screening were made routine and are provided to all pregnant mothers in government health facilities. And these programs are being integrated into the MCH services aimed to provide quality and comprehensive antenatal care to all pregnant women in the country. As you can see from the graph on the left side, you can see that roughly approximately 500,000 antenatal mothers were screened for HIV as well as for syphilis, and reaching more than 95% coverage of antenatal mothers screened. And if you can see, the same time, the seropositivity for both for HIV and syphilis are declining. However, we see a slight increase to 2017. Now, on the right side of the graph, the pictures are showing the MTCT rate of HIV and syphilis. Now, the PMTCT intervention that entails giving or provide a provision of ARV to HIV-infected pregnant women and also penicillin to syphilis-infected pregnant women, plus the prophylaxis to the HIV-exposed babies, have resulted in the significant decline. If you can see from the pictures on the right, both vertical transmission of syphilis as well as HIV has declined significantly, and you can see it continued to further decline into 2017. Next. With regard to the EMTCT criteria indicators, now Malaysia has met the criteria for elimination in 2016 when the estimated MTCT rate for HIV reached below 2% for the first time. Although, if you can see, we also share with you the programmatic data of MTCT rate for HIV. Now, basing on the programmatic data of MTCT for HIV, Malaysia actually has reached less than 2%, below 2% since 2013. However, I think it is requirement to have or to show the estimated MTCT using spectrum. So only in 2016 we reached below 2%, and we submitted the request for validation 2017. And in 2017, you can see that the MTCT rate has further declined to 1.77%. We do not have, Malaysia has maintained the annual rate of new HIV infections as well as annual rate of congenital syphilis per 100,000 live births below below 20 per 100,000 live birth, if you can see from the table shown in front of you. But these are all impact indicators. As for process indicators, Malaysia has achieved the all impact indicators, which is 95% and above, antenatal care at least one visit, HIV syphilis screening coverage exceeding 95%, and also treatment coverage for HIV and syphilis infected mothers also reaching above 95%. Next, please. Okay, now following the certification of elimination of vertical transmission of HIV and syphilis, Malaysia has embarked on efforts and initiatives to further improve the service delivery with aim to sustain the elimination status. Well, currently, we are in the final stage in reviewing and updating the PMTCT guideline for HIV and syphilis, and scheduled to be circulated to all healthcare providers, both in private and government facilities, through a Director General of Health circular. So we aim to have the syphilis guideline circulated by February this year, and the PMTCT HIV updated guideline for circulation and retraining by May this year. Now, what is important in this updated guideline for PMTCT, syphilis, and HIV are the adding, the stressing the importance of testing and adherence to treatment, and most importantly is to update the options, delivery options, and infant feeding options in line with the WHO guideline. And there's another new important significant changes in our guideline would be requirement to report stillbirth and the requirement to test, retest syphilis for mothers who has stillbirth as their outcome of delivery. And another new thing that we have developed was last year, the formation of a national committee for PMTCT syphilis that consists of various expertise. Among others are the ONG specialists, the PEDS ID, neonatologists, dermatologists, pathologists, MCH, and also the epidemiologists. And the main agenda or main function of this National Committee for PMTCT would be, among others, to review each and every case of congenital syphilis to see whether it suits the WHO case definition before we final and take it as congenital syphilis. And we are, for this year, for 2018 cases of congenital syphilis, we have in our aligned list less than 20 cases, and that will be tabled soon on the 12th of February for us to finalize cases of congenital syphilis in Malaysia. And apart from the PMTCT guideline, we are also in the midst of working with the Islamic Development Department on the training module for premarital for Muslim. So it is important to stress again on the early booking and the need for repeat testing for high-risk pregnant mother. And also during this training module for young couple who wish to get married, we also would like to stress again the importance of getting the spouse to test for HIV. Next.
Anita, it's Lori. About 5 more minutes, please.
Yeah, sure. I'm finishing. All right, the key lesson learned that would like to share is to succeed in elimination of HIV and syphilis vertical transmission. It is very important to have a political commitment, and we have EMTCT emphasized in every series of a national strategic plan, and the last series of strategic plan is National Strategic Plan for Ending AIDS 2016 to 2030, and for Malaysia. The commitment has been translated into the domestic fund, where 95% of our HIV responses are domestically funded. And PMTCT must be integrated fully in IMCH services in order to be the elimination process to be successful. And for Malaysia, we have more than 300 family medicine specialists placed in more than 1,000 government clinics, providing antenatal care to about 83% of pregnant women in the whole country. And for Malaysia, 97.4% of women in Malaysia had minimum of 4 antenatal visits. And on top of that, home visits are also one of the key component in MCH service delivery. And to ensure that all mother who miss opportunity for HIV test for the unbooked mother will be tested during intrapartum and treated accordingly. And on top of that, the tracing of cases to ensure that mother adhere to treatment. The district health office would trace all cases lost to follow up if they are informed by the attending physician. And for prevention of unintended pregnancies through premarital HIV testing, this program has been expanded to also involve the non-Muslim. Next. Okay, you can see the graph, the premarital on the right side, the HIV prevalence among premarital. Every year we screen more than 250,000 premarital couples, all regardless of ethnic and regardless of religion. But you can see that zero prevalence has declined tremendously. Next. And key challenges to maintaining success, we do have, especially with regard to high-risk mothers. Although we have screened more than 95%, there are still small percentage of those who are at high risk, who are actually latecomers, and either they lost to follow-up and non-adherence. As we know that high-risk mothers, because of stigma and discrimination, they are coming late. And to overcome this, we empower communities, civil societies, through the Malaysian AIDS councils to have focal group discussion, frequent focal group discussion to find out what are the issues. And at the same time, Ministry of Health are also producing recently a module to combat stigma and discrimination among healthcare workers that would be due to first training conducted this year. And of course, our second challenge would be the migrant women, where beginning 2014, the government has imposed some fee for basic antenatal care consultations. However, for those mothers, migrant women who are found to be positive, they are given free antiretroviral and also prophylaxis to the HIV exposed babies and free formula feedings for 24 months. However, the ARV will be given during antepartum. It will be stopped or imposed. A fee will be imposed for continuation of ARV to the mother after delivery. And the majority of, however, majority of migrant women access antenatal care service in public sector. You can see 77.7% still access antenatal care services in public sector as compared to private sectors. And UNHCR card holders, those migrant or the refugees, enjoyed 50% discount for lifelong ART for option B+. Next. And experience of South-South cooperation and learning with other countries. As you know, that Malaysia just joined in the country that has achieved elimination recently. It was 8 October last year. So we only had experienced the first webinar hosted by WIPRO on the 5th of December, and also invitation to share our experience during the Shield Zero Transmission International Forum hosted by the Chinese Foundation. Next. So the recommendations for successful South-South cooperation, I have listed 3 over there. You can see enhance capacity building through sharing of expertise within member countries, promote learning and solution sharing from other developing countries through showcasing of best practices and challenges and results, study results. And of course, lastly, facilitate sharing, transfer of knowledge, technology, skill, inventory of resource persons in the region. Thank you.
Thank you so much, Anita. Another very rich presentation with learning for other countries, and we appreciate both Thailand and Malaysia's successes and willingness to share that learning for other countries. So thank you. I have one question to take at this time, and that the question is, are services for maternal and child health and antenatal care free of charge in Malaysia?
Yeah, for Malaysian, the antenatal care services are free of charge, but not for the non-Malaysian. There will be some fee imposed.
Great. Thank you so much. We're going to keep moving along, but I think we will come back for more questions in the question and answer. Oh, here, I do have one for you. How public-private linkage was made in Malaysia?
We are not they're talking about antenatal care. It's provided both private as well as government health facility. But as for private facility, all cases mothers who are detected HIV positive will be referred to the government facility for free ART. So through our survey that we did last year, all 100% of private facilities did provide HIV and as well as syphilis screening, but once positive, they will refer the mothers to detect the mothers and refer back to the government facilities for that, so that the mother can get free access treatment.
Great. Thank you so much. And you had just one comment appreciating the excellent recommendations you made on South-to-South cooperation. So thank you for that. Now, I'd like to turn to our next speaker, my dear next door colleague, Dr. Mariam Silla, who is the Chief of Health and Nutrition at UNICEF South Africa since March 2018. Prior to this assignment in South Africa, Mariam served in various capacities in UNICEF, including in Burkina Faso and Ethiopia, the regional office for West and Central Africa in Senegal, and at our headquarters office in New York. Prior to UNICEF, which she joined in 2002, Mariam worked as a medical doctor and technical advisor at the Conakry City Health Directorate in Guinea, and served as a global health fellow for the World Health Organization's global program on evidence for health policy in Geneva, Switzerland. A national of Guinea, Mariam holds a medical degree from the University of Conakry and a master's degree in public health from the Johns Hopkins School of Public Health. Mariam will now share with us the experiences and lessons learned in dramatically reducing new HIV infections among children in South Africa. Over to you, Mariam.
Thank you very much, Laurie. Greetings, everyone. Good morning, good evening, good afternoon. Next. When it comes to South Africa, the epidemics is quite one of the biggest, or the biggest HIV epidemics in the world, with an estimated of more than 7 million HIV infected. Just 1 minute, I need to. Okay. It's also, South Africa also has the largest ART program in the world. currently it is estimated that close to 4.5 million are on IRT in South Africa. And this has even undergone a more expansion since 2016 with the implementation of universal test and treat policy. So the HIV prevalence among South Africans of all ages in 2017 was estimated at 14%, which will, if you take into account the size of the population estimated at 57 million, it gives you an idea of the sheer volume of the epidemic. Next, please. So I deliberately left the last point on children because I wanted to highlight the achievements. As you, South Africa initiated its PMTCT program only from 2002, which are much later than the countries that have presented and achieved elimination, but it also underscores that the country must be credited for rapidly reaching the, for rapidly achieving some of the results that I will be presenting. When you take into account that the program started only, the national PMTCT program started only in 2002. You can see, for instance, from 2010 to 2017, the PMTCT coverage is quasi-universal. It went from 94%, but if you go before 2010, it was even much less than that, but now it's quasi-universal in South Africa. But also, the mother-to-child transmission rate has been halved between 2010 and 2017 for 10% to less than 5%. It's currently estimated at 4.3%. So great achievement in short, in few years of implementation. Next. If you look at this slide, you will see that pregnant women receiving ARVs compared to the pregnant women living with HIV, you will see the huge progress that the country has made. Almost 100% of pregnant women that are living with HIV are receiving ARVs, which is a great achievement once again. Next. When it's come to HIV infections in children, you will see that the country has averted an estimated 475 new pediatric infections since 2009. When you look at the dark blue, I'll call it the dark blue or green, from 2009 to 2017, it's been decreasing in an impressive way. The new HIV infections among children 0 to 14 has dropped from 38,000 in 2009 to less than 13,000 in 2017. Even though it's 13,000 too many children that are being infected, but it's an improvement of a reduction of more than 70% or close to 70% reduction in short years. Next. So as I've highlighted few of the indicators and showing great improvement, not only in coverage, but in reductions in terms of percentage, I would like to highlight some of the lessons that we've learned in achieving these results. First of all, as it's been mentioned by the previous presenters, strong political leadership in commitment, especially in South Africa. Like I said, the national program implementation only started in 2012. So this political commitment at the highest level has made a great difference. Political commitment, not only leadership, not only at national level, but at all levels has been key in helping to achieve these results. The second thing, what has also been important is having policy informed by evidence. South Africa was very quick to integrate or to adopt and adapt new biomedical interventions or new evidence into its policy and quickly roll it out at all levels, from national, provincial, district, and lower level. It was its rollout. The third lesson that we can at upstream level is the strong coordination, not only by the national HIV response was coordinated by the South African National AIDS Council standard, which ensured that the country has one plan, one response, but also played a key role in terms of advocacy so that government can adopt new interventions. Last point on this lesson learned at upstream level or in terms of policy, coordination, and collaboration is a strong partnership among development and implementing organization, academia, and CSO. This also has been very important for South Africa to try out new strategies and then roll them out quickly at all levels. Next. So here I want to dig down a bit about some of the key, in terms of translating policies into results. I would like to highlight a few things. All plans that were developed to transform the policy into results had key elements in common. One is evidence-based planning, monitoring at decentralized level. Data to not only make sure that data was one thing, I think it's been already mentioned, but the country also developed a dashboard to monitor some key indicators at national level, provincial level, and district level. I think this was very important from 2008 onward, but also it was allowed to tailor interventions according to epidemiology, number of cases in a number of cases, and the capacity of district to implement. I think that was one of the key elements also that we could highlight. The third element is the cascade. I'll come that on the next slide. The cascade that the country used, because at the beginning the dashboard was mainly based on percentage. Then with the 99%, the 99.9 elimination or the drive for the 99.9 program, as well as has allowed not only to focus on percentage, but to focus on number, which is a very important thing for South Africa. Because if you look at the process indicator, we are doing very well, but when it comes to numbers or the impact, that's where South Africa is not reaching the goal for the elimination. I think, as mentioned by Dorothy, this is something that we need to look at when it comes to the certification or what could be put in place for South Africa. I think I've highlighted the key important thing here was data at all levels when it comes to the decentralized planning, implementation, and monitoring. Next. So I just wanted to highlight these figures when it's come to the cascade. And it shows the strong platform that South Africa has when it comes to antenatal care. You will see that almost all pregnant women, and like I mentioned, all HIV positive pregnant women were tested. They know their status, and 97% those who know their status are on treatment. The same goes for early infant diagnosis at birth. It's over 90% or almost close to 95%. However, we have a lot to follow up, especially when after 10 weeks, where it's become more important. So when I come to the challenges, which is the next slide, please.
Mariam, it's Lori. About 2 more minutes, please.
Okay. Thank you. I will highlight few challenges to fast track or to improve or reach the last mile in South Africa. I think, as I mentioned, our antenatal care platform is strong. However, when it comes to the postnatal care, we need to do more and do better at reaching children after birth and ensuring that they do the treatment, to adhere to and retain them on treatment. The other area where I would like also to mention is sustainability of interventions. Like Malaysia and Indonesia, South Africa is fully or almost fully funding its program in PMTCT. How sustainable that will be when you are putting more and more children and women on treatment, lifelong treatment, but also as they age, if this is being complicated by non-communicable disease. So I think in the long term, this is something that will require some reflection. And the other for the program to continue, and the last, as I've mentioned that already, is reaching elimination in South Africa due to large burden of HIV infection. Next. So just three things that I would like to highlight on experience out of South Africa hosts biannual AIDS conference that allow to share research and best practices, including collaboration with other countries. We also provide, South Africa also provide a lot of technical assistance and have strong research institutions in South Africa, as well as recognized experts that provide, that inform actually a lot of recommendations that are made at global level. Next. So here I would like to emphasize our recommendation for a successful South-South cooperation. One is, how do we even engage not only governments, but also civil societies and academia in this South-South cooperation as today's discussion. For now it's government, but how do we expand it? The next one is, how do we engage the decentralized level? For instance, team at district level from Malaysia working with team at district level here in South Africa or somewhere else. How do we, for me, that's one thing that could be, it's very important to look into. I think the rest has been mentioned by my colleagues, conferences, collaborative research, but the first two, I will emphasize that. Next. I think this was the last slide. Thank you very much.
Thank you so much. Another terrific presentation in a very, very different context. So thank you for that. I'm going to ask you one of the questions I have now and then save the other one for the discussion session at the end. So Mariam, has there been high demand from other countries in Africa to learn from the South Africa experience?
Well, this is a challenging question when it comes to others. So, you know, South Africa is quite different in Africa, given its status in high income or middle high income countries, strong health system, relatively strong health system. Maybe the request would be in terms of processes, but how to replicate South Africa experience in the rest of Southern Africa would be probably the neighboring countries. Yeah, I know I'm not. I didn't respond fully to the questions, but I just wanted to put it in the context.
Thank you. No, that's very helpful. I mean, I think there are a lot of visits to South Africa, but I think you're right. The context is different. So thank you. And now I'd like to turn to Dr. Melanie Taylor, who's going to talk to us a little bit more about syphilis, which is sometimes the underappreciated aspect of all of this. So thank you, Melanie. Melanie is a medical officer with the World Health Organization's Department of Reproductive Health and Research, the Sexually and Transmitted Infections Program. She's seconded from the U.S. Centers for Disease Control and Prevention. Melanie works primarily on EMTCT of HIV and syphilis and global STI surveillance. She is an infectious disease physician. It's nice to see you, Melanie. Melanie will share some brief remarks on expanding syphilis screening and treatment in antenatal care. Over to you. Melanie, you're muted, I think. We can't hear you, Melanie. Do you have your mute button on?
Yes, now it's working now. So if everyone can hear me, just a quick thank you for the opportunity to participate in this webinar and the opportunity to talk a little bit more about WHO's dual elimination of mother-to-child transmission program, which includes both HIV and syphilis. And I think in listening to the presentations thus far, to have just a few summary statements, it seems as if there is clearly the focus and the emphasis on universal healthcare access and universal antenatal care coverage. But there's also, even among the countries that have been validated, they would be quick to tell you that the services and surveillance for syphilis in antenatal care are less well developed than those for HIV. And that is due to a historical lack of advocacy, funding, and also program development for prevention of mother-to-child transmission of syphilis, which, as you all know, is the second leading cause of stillbirth globally. The first leading cause of stillbirth is malaria, and the second leading cause of stillbirth globally is syphilis. Syphilis is prevented with testing and treatment and only requires one single injection of benzathine penicillin to prevent mother-to-child transmission. So I wanted to talk, if you could advance to my first slide, I would like to say that even though we have the ongoing emphasis for dual elimination through WHO, and we are very proud to have partners like UNICEF to promote the dual elimination inclusive of syphilis within their programs. And we're very proud to say again that Malaysia and Thailand did achieve dual elimination, and we hope that other countries within the South-South collaboration will consider that kind of an expectation from WHO, that you strive towards dual elimination, dual path to elimination, but at minimum reporting on your coverage of syphilis testing and syphilis treatment during antenatal care. As an example, what I'd like to say is that even though we are moving in that direction, there are still large differences between the testing coverage of HIV and the testing coverage of syphilis. And much of this has to do with the fact that testing for syphilis falls within the Ministry of Health's purview to purchase test kits and purchase benzathine penicillin. There is also some reticence to treat with benzathine penicillin, even though we know it's a very safe drug and is still highly effective without antimicrobial resistance against syphilis. But we see in some of our largely populated countries in Southeast Asia, in also the Western Pacific, as well as in South Africa, Central Africa, and West Africa, these large differences in testing coverage for HIV and syphilis mean that there are infants and mothers experiencing adverse birth outcomes due to untreated syphilis. Next slide. And those syphilis, there you go, very good, thank you. And this slide demonstrates that women, the adverse birth outcomes that occur to pregnant women, they most often occur among pregnant women who are in antenatal care. This is the biggest tragedy of congenital syphilis globally, is that the women that experience stillbirths have been in antenatal care, but they were not tested in the solid blue bars on the slide, or they were tested, but they were not treated, which is in the light blue bars. And this tragedy can easily be overcome with the inclusion of syphilis testing for every pregnant woman alongside that of HIV, where we need to reduce the gap in service delivery for syphilis testing. Syphilis testing is inexpensive. Benzathine penicillin costs anywhere from 20 cents American to 50 cents American, when we know that only one injection is required. And we often see this testing gap in many countries across the world, not just in the South-South countries. Next slide. But what it's important to note is that there are new technologies which are now allowing for the immediate reduction in gap of HIV testing and syphilis. And what I mean is that there exists a rapid dual test whereby with one single finger stick, a woman can be simultaneously tested for HIV and syphilis, and at least for syphilis, assuming she receives a positive test, she can be treated in the same visit with an injection of benzathine penicillin. Now, why is this important? It's important because we know that this rapid dual test will simultaneously test for both infections. We know that it is first and foremost an HIV test with test characteristics and test performance that is on par with single HIV tests. This test, or at least one test so far, and we expect another test within 1 month, has been WHO pre-qualified for use. And thirdly, we know that this offers the opportunity for immediate treatment for pregnant women who are diagnosed with syphilis. We are aware that there has been quite a lot of adoption of this test through the South countries and even extending into the countries in South America and Central America as well. And this is in direct emphasis for the elimination of mother-to-child transmission of syphilis, in addition to that of HIV, because we know that WHO has a dual elimination program. It is the expectation of WHO that countries would strive towards dual elimination. We also know, as I mentioned before, that syphilis is the second leading cause of stillbirth globally, and this is a very inexpensive and cost-effective intervention for pregnant women, for each and every pregnant woman. Next slide. So as a quick review, I'd just like to say thank you to the 3 countries that presented on their experience with HIV, and for those that presented also on the experience with syphilis, EMTCT actions, strategies, and priorities for those countries that were validated for dual elimination, both Malaysia and Thailand. For maintenance of validation, we remain very proud of you as key examples for the rest of the world. In specifically your activities related to elimination of mother-to-child transmission of syphilis. We know that there are challenges related to advocacy, prioritization, and even policy support at some national levels, but we assure you that there is the availability of rapid syphilis tests and now rapid dual HIV syphilis tests, which can be purchased with with donor funding, including funding from the Global Fund and the United States PEPFAR funds. This HIV test is, as I mentioned, on the same cartridge as that of both infections. And then, of course, the treatment of pregnant women with syphilis is with benzathine penicillin. 1 injection is required for prevention of mother-to-child transmission, although maybe more injections would be required for full treatment of the mother. But this injection is a one-time at least, and it is quite inexpensive. We also recommend, of course, as do our HIV partners, partner management, which includes testing and treatment, so to prevent reinfection of this pregnant woman. I'd like to stop at this point and then again say that I'm very proud of the South collaborative effort by UNICEF, and it is a true pleasure and honor to be on this webinar today. Thank you very much.
Thanks, Melanie, and we are very happy to have you. Thank you for the very clear presentation, and thank you again to all panelists. We've made time and left a bit for discussion, so I want to move quickly to some of the questions we have on hand. And I'm going to come back to you, Dr. Sarawut. I have a few questions for you, so I'm hoping that you can note them down and respond to them. The first question is, can you give us a sense of some of the community level activities and actions that were taken by Thailand for EMTCT? So the first is about community level actions. The second is, what is the coverage of formula feeding in Thailand?
Okay.
And the third, good, I'm glad to hear your voice. What criteria was used for stratification of high-risk pregnant women living with HIV?
Okay, thank you for your question. The first question is about the involvement of the community level, right? Yeah, in Thailand, we have the policy from the central area into the regional and into the community. And Thailand, we have the health committee in the community. Many the healthcare provider in the community and the NGO work together. And we have the medical doctor or the family doctor work in the community level. About the access to medical services, we have the health volunteer in the community work with the healthcare provider. All of them can to get the guideline from the central for the patients in the community. The highlight of the healthcare worker in the community is the healthcare volunteer. This is an important issue. And the second question is the coverage of the breastfeeding in Thailand. In Thailand, we have the national policy for the breastfeeding to all the baby delivery from the woman, and we have the London Milk Code for protect the some promotion of the formula feeding, and for the exit breastfeeding in the last survey from year 2016, we found about 26%, yeah, for the survey about the exit breastfeeding. But we have the problem about in the community and in the regional area because most of the mother go to the center. That go to Bangkok and go to the big city for working and have the problem to give the breastfeeding to all of them. But for the HIV positive women, we provide the formula feeding to the baby. But if the mother requests want to give the breast milk to the baby for the HIV positive, we have to counseling to all of them for the high risk for transmission rate if give the breastfeeding to all of them. But no problem in Thailand because of we give the counseling before ANC. Okay, the last question about I forget the question. the last question is
the criteria for the criteria for a high risk pregnancy in a woman living with HIV.
Okay. For the criteria for the high risk, we have the London policy for the high risk criteria, mother and the baby. The first one is the viral load more than 50 copy nearly delivery, and the second, the mother not receive the ARV complete 4 weeks until delivery. We have to set this the high risk criteria, and we have to give the Leuticavir and give the ARV for the continual to all of them, and the elective cesarean second perform if need for reduce the transmission rate.
Great, thank you so much. I'm going to move now, Melanie. I have a quick one for you, and that is the rapid syphilis test confirmatory of active syphilis?
In Thailand?
No, this was for, sorry, Dr. Sarwat, this is for Melanie Taylor on syphilis.
Hi, thank you. I just want to make sure you can hear me once more, Lori.
Yes, we can hear you clearly.
Yes, we have an algorithm for the diagnosis and treatment of pregnant women with syphilis, within which we set a cutoff whereby we would recommend a second test for the understanding of whether or not the mother has old or new syphilis. However, the rapid syphilis test is confirmatory of either active syphilis or past syphilis. Thus, if the woman is not able to account whether or not she's received a somewhat painful injection with benzathine penicillin, then she needs treatment for syphilis with benzathine penicillin. In summary, the rapid syphilis test we have now is a confirmatory test. However, in some regions where the prevalence of syphilis is greater than 5% among pregnant women, it is possible that the woman may have already had and been treated for syphilis, in which case a second test could be performed after the benzathine penicillin is administered. We don't want to miss the opportunity to treat the woman at the time of that positive test. So it is possible to do a second test to confirm the diagnosis as active, but we recommend clinically that a woman with a positive rapid syphilis test receive benzathine penicillin at the same visit.
Thanks very much. Very helpful. Mariam, I have 4 questions for you, and I'm going to go ahead and read all 4 and then turn over to you. The first question is South Africa offering free formula feeding or promoting breastfeeding for women living with HIV? The second is, how can South Africa help countries with very low HIV prevalence, such as Somalia, in achieving the same results? That one could actually go to the other countries as well, but I'll let you take a first stab at it, Mariam. The third one is, I believe the great achievement of South Africa was public awareness. Do you have any resistance or stigma that made it challenging? And then the last one is, what is the retention rate of pregnant women on ART at 12 months?
Okay.
Over to you.
Okay.
Mariam, are you on mute?
Yes.
Can you speak up a little bit?
Yes, yes. Thank you very much. Let me come back to the question. The first question was about free formula. South Africa, starting 2011, end of 2011, from 2011, decided that exclusive breastfeeding is the way to go is the way to go. So free formula is not provided. On the contrary, exclusive breastfeeding is promoted. The next question was how South Africa could help. Maybe I'll go to the public awareness, the retention, and go to that question first. In terms of public awareness, I think the strong leadership, political leadership, from 2008 from 2008 when the denial of the existence of HIV/AIDS ended, made a big difference, because there was a national campaign in South Africa, a national campaign of 18 months to do testing and counseling, testing, and get people on treatment. I think that's made a big difference in those years, so that the stigma diminished. But also, the fact that treatment was available free of charge, and that in every health facilities you could access treatment, also made a difference there, because having campaign, being on TV, if you don't have the service available, would have been would have a boomerang effect. So public awareness is something, but stigma still exists. I'm not saying it's completely erased, but it's less so than it was like 15 years ago. Mostly because of you have people that publicly declare their status, that are public figures. I think and Nelson Mandela actually played a key role when he acknowledged that his son died of HIV. Retention on ART after 12 months, you said? What was after?
So we don't have exact figures because we don't disaggregate our data according to those that are pregnant. So we can tell you we have good estimates and data for 12 months, but you form part of a cohort based on how long you've been on treatment, not whether you're pregnant when you start treatment or wherever you initiate it. So our retention figures are all based on duration of treatment and not disaggregated by whether you were pregnant when you started. And therefore our retention figures don't really give us an indication on whether the woman is still on treatment 12 months later. What we do follow up with though is, because of the breastfeeding, we still do have that 18-month test, which is universal. And coming up now with a new policy and guidelines that are going to be released, we actually have to monitor the woman's viral load. at 6 months, at 12 months. So we will be able to disaggregate that data better.
Now, the last question, I'll try, maybe other panelists will come in, how South Africa could help countries like Somalia or any other countries. I think the process that was taken in terms of adopting evidence-based interventions, but also translating policy into action is something that many countries on the continent can learn from. Because if you go to any countries, you take the policy document, the operation plan documents well written, you take every single, you'll see that everything is perfect on paper. But translating that into results is where maybe some of the countries could learn from South Africa. And what was some of those lessons? One is commitment and accountability for results. I think that's important. Maybe Rwanda is not on the panel, but it's a good case. It's a good study. It's a good example. Second is data to make sure that you are following your program. So that I don't want to go on and on, but I think some of the good practices, lessons learned from South Africa, could be replicated in every country. Now, as I mentioned, I know South Africa is more advanced, but the principles that the country use could be applied universally.
Thank you so much, Mariam. That was very helpful. I have a few more questions. I'd like all of the presenters to please turn their cameras back on. We are due to close in 2 minutes. I've been told I can extend for 10, but I want to make a couple of points before I ask another question, because I know some of you will need to sign out. And one of those points is we will continue the discussion and have the questions and answers on the community of practice, socialprotection.org. So if you have not joined, please do join. And the second is that there will be a survey released to you shortly after the webinar, and if you could please chip in and answer to help us improve future webinars, that would be terrific. So I'm going to continue with a couple more questions. Maybe first ask the other countries whether they have any comment on helping some of the lower prevalence countries like Somalia, Ethiopia, other places like that. Anita, can I ask you?
Yeah, Malaysia is a country with concentrated epidemic monkey population. So if you look at my first slide, the seropositivity is still low, 0.05% to 0.07%. But what is important for country with low prevalence, they need a very strong political commitment, because if you want to screen all antenatal mothers, we need enough fund actually. So therefore, political commitment is the way to go. Or next option would be focusing on high-risk mothers. Right, so therefore, I think for country with low prevalence, probably you need to come up with a criteria or definition of high-risk population among antenatal mothers to be screened. Yeah.
Thank you so much. Very helpful. Dr. Sarwat, can I ask you a very quick question, which is for the high-risk pregnant women living with HIV, how long is raltegravir given after delivery?
For guideline of national guideline of Thailand, we provide the raltegravir for the pregnant women for the late placenta. And after that, after delivery, for a week, we have to continue to ARV. The same ARV, I mean that about the heart therapy to the pregnant women.
Thank you very much. Mariam, another one for you. What is the situation of the epidemics with adolescents, in particular pregnant adolescents living with HIV in South Africa? Mariam, are you on mute?
Yeah, I unmuted. Can you hear me now?
Yes.
Yes, it's a serious, if there is a key population, I call it key population, that the country needs to focus on is adolescent girls and young women. they are more likely, at least 8 times more likely to be HIV positive than their male counterparts. And when you look at pregnancy among adolescents, it's in general very high, as in many countries in sub-Saharan Africa. But also the challenges when it's come to adherence to treatment, retention to treatment is even higher in adolescent girls and pregnant and women, young women, than in the general population. So yes, it's a huge challenge, and the country has started to face it by rolling out few policies, few plans and programs like the She Conquers program, which is a national campaign to sensitize, get the girls on treatment, get the adolescent girls or adolescent young men are tested and on treatment and retained, and partners are strongly supporting the government to do that.
Oh, I was on mute. I'm so sorry, Mariam. There's one more question to you about your amazing statement, and for you to please describe the coordination system that allows South Africa to bring people together towards EMTCT. So what is the coordination system?
The coordination system, can you hear me? The coordination system in place, there is at national level, the PMTCT technical working group, where you have academia, implementing partners, national level, national Department of Health that coordinate the programmatic side of things, like reviewing new approaches, how the country should adopt it and roll it out. And I think that was key in moving the program forward, because there you have a good representative of different factions of partners based on their comparative advantage, and they provide input when it comes to implementation, and that is replicated at provincial level. Now, when it comes to advocacy, SANAC and other civil society organizations also played a key role in, I don't know if I should use pushing the government, but making sure that the government adopt and adapt new interventions and new strategies.
Thank you so much, Mariam. Now listen, there's still some questions coming in. I'm going to take one more for Dorothy, but there really are still some interesting questions, including one from a colleague of ours in Burundi asking about this work in conflict settings. So I really want to encourage people to go to socialprotection.org where we can continue the dialogue. But a last one to Dorothy, which is almost what I've just said. It says, to Dorothy, are there existing global networks where we could continue these discussions, or do we need to create one? Now, I've mentioned socialprotection.org, but please feel free to add other resources and places that people can go.
Thanks, Lori. I hope you can hear me. Yeah, the existing networks actually were the IATT platforms that no longer function. So the socialprotection.org would be a very interesting platform to explore, where countries can have this exchange and where learning can happen. You know, so I think that building on what we have today, if we use that platform effectively, it can be a really important clearinghouse for learning between countries, and also just providing opportunities for technical assistance and so forth. So right now, for EMTCT, there's nothing more than what you have already said, and so this is a great opportunity. Thank you.
Terrific. Thank you. So all of our listeners, you've heard it. Let's all join socialprotection.org and continue this exciting conversation. I really want to extend thanks again to all of our excellent panelists and to the audience who joined us for this rich presentations and really interesting Q&A. There's a lot out to be learned. There were about 12 points made on how we can improve and do more in South-to-South cooperation, including much more engagement of governments in an active role, collaborative research, knowledge management down to district level, and others. So really some very exciting ideas on the table, and thanks to everyone, and wishing you all valuable sharing and more learning for children. Thanks so much.